So our last speaker of this session is going to be Kevin Ghassemi. So he's one of our homegrown talents here. He got his training here at UCLA. And he's also the Associate Clinical Program Director for our Esophageal Disorders Center here at UCLA. And he's going to be talking about GERD and what to do when the PPIs don't work. Kevin.
So my task today is to talk to you about what to do with GERD when the PPIs don't work. So I'll talk a little bit about the background of GERD. We'll talk about PPIs, what to do when there's a partial response or what it means when there's a partial response, what if the patients don't respond at all to the proton pump inhibitors, and then anti-reflux surgery. So just a little bit of definition to start. So GERD is defined as reflux of stomach contents into the esophagus, which then cause troublesome symptoms or complications. And we define severe GERD in particular as GERD which occurs at least twice a week. Now, GERD can be either erosive or non-erosive. Non-erosive means that the esophagus still looks normal when we take a look at it. And erosive esophagitis means that we can see the inflammation endoscopically. So this slide is a composite of several studies looking at the prevalence in the population of GERD over time. And really, although from study to study the prevalence varied, it seemed to stay pretty constant in each study, meaning that all ages of patients will have GERD, and as you get older, it's not necessarily more common. Now, there are several reasons why GERD can occur. You can have dysfunction of the lower esophageal sphincter, which can allow for stomach contents to move up more freely. You can have poor clearance from the esophagus. The esophagus actually tries to push things back down, and if that's not working, well, you're going to probably have GERD as well. Hiatal hernia is very common, especially in Western society, and is probably in part related to increased intra-abdominal pressure forcing the stomach through the diaphragmatic hiatus. And then finally, patients who have problems with emptying will also have GERD because the contents need to go somewhere, and if they're not going to go out very easily, they're going to try and go back up. Now, there are a lot of ways that patients can present with reflux symptoms. The typical ones are heartburn and regurgitation. That's what we tend to see most of the time, although in the gastroenterology practice, we also see a lot of extraesophageal and atypical symptoms. Patients may also have chest pain. They may complain of swallowing difficulties. They may have nausea, bloating, dyspepsia, which is defined as upper abdominal discomfort, or their main symptom may be that they're just belching more frequently than they would consider normal. And then the part that becomes very confusing are these extraesophageal symptoms, such as cough, laryngitis, globus sensation, which Dr. Avsiewicz talked about. Patients may have asthma, especially adult onset asthma, dental erosions, pharyngitis, sinus problems. A lot of patients with the condition idiopathic pulmonary fibrosis, it actually may be related to reflux. And even recurrent otitis media has been attributed to reflux in some studies. So the crux of treatment for reflux is with proton pump inhibitors. And just a little bit of background on them. Really, the effect of the medication is dependent on activation of the proton pumps, which is the uptake of the pumps into the luminal lining of the stomach is eating or even thinking about eating. So you want to take these medications before bedtime, usually about 30 to 60 minutes ahead of time, so that the medication is at its highest concentration in your system, ready to bind those pumps when they're going to get activated. And the half-life is only about 90 minutes for the most part, so if the patient takes the medication and then 4 hours later decides to eat, you're not going to get that same type of bang for your buck in a sense. And a lot of patients with nighttime symptoms, they'll take their medication before bedtime because, again, the concentration is higher, and that's when you figure you want to take it. But again, the pumps are not really going to be activated during that time, so that's not really the time you want to have the patients take the medication. It's not that it won't work, but again, you won't get the most effect from the medication at that time of dosing. So let's look at the different PPIs in terms of their overall efficacy. This is looking at suppression of gastric acid production, keeping the pH greater than 4 in a 24-hour period. So going from left to right, you have pantoprazole, lansoprazole, omeprazole, rabeprazole, esomeprazole, and then the newest one, which is dexlansoprazole, which is actually a once-a-day dosing drug that functions like twice-a-day dosing. And the doses I'm using here are as if you were taking once a day, or in the case of dexlansoprazole, the minimal dosing. pH suppression, or gastric acid suppression, is pretty similar, although slightly increases, and with the esomeprazole and the dexlansoprazole, you do get above 12 hours for the most part. But really, what does that translate to in terms of clinical response? Because the pharmacokinetics really don't differ, also there's very little clinical differences in terms of control of symptoms, healing of esophagitis. In one study, esomeprazole was found to be slightly more effective at healing erosive esophagitis than the other PPIs, but the difference was between 92% and 88% approximately. So overall, you're still getting very good healing. So to me, the most important factor is to consider is what's going to be the most, what's going to be the cheapest one for the patient? Is it going to be the one that you prescribe, or is it going to be telling them to go to their drugstore and get the over-the-counter version? Or they can go to Costco and buy it by the barrel full. Okay, so we've talked about how to treat the patients with reflux, but what happens if they don't respond the way that we would hope, i.e. completely? So if you have someone who gets some response to the PPI, it's probably that you have the correct diagnosis, but maybe the way that they're taking the medication is incorrect, such as they're not taking it at the proper time. That's one of the most common things I see in my clinic. Or maybe they need a higher dose. Maybe they're having nighttime breakthrough symptoms or breakthrough reflux. Or there may be some issues with lifestyle that they need to address, and it's not just about taking a pill. We also have to consider that maybe there's a coexisting disorder that's preventing full response to the PPI. So we'll talk about that. So first, let's talk about twice daily dosing. For the most part, once a day dosing will provide adequate 24-hour relief of symptoms for most patients. However, about 20% of patients who are considered either partial or even non-responders to the once-a-day dosing may find relief with twice daily dosing. Now, it's important that you still have the patients take it before meals, so before breakfast and before dinner is usually the appropriate timing. Now, nocturnal reflux is a somewhat debatable subject, but it is seen in about 30% of patients with reflux. The reason why it's a little bit debatable is that there seems to be an unclear association between when the reflux is occurring and when the symptoms are occurring. So patients who may have nighttime reflux based on a pH study may not necessarily have their symptoms persisting still at night. They may still have symptoms persisting during the daytime, which may not correlate very well. But this has raised the possibility of adding an H2 receptor antagonist such as famotidine or ranitidine taken at bedtime to help control the symptoms. And usually it's a high dose, so 300 milligrams of ranitidine or 40 milligrams of the famotidine. And in some studies, up to 70% of patients had an additional symptom response. So this is something to consider. Now, one other thing to consider is that some patients may develop a tolerance to this medication because it's really only blocking one of the three ways in which gastric acid production is stimulated. However, if you're combining it with a proton pump inhibitor, which blocks the final common pathway, you really shouldn't have to worry about tolerance. So lifestyle modification is quite a big thing. Patients come to my clinic having cut out everything under the sun, still having reflux. Their quality of life is actually worse because now they're not eating anything or they're missing their cup of coffee in the morning. So what can we have patients do from a lifestyle standpoint? Well, one of the most significant modifiable risk factors is weight loss. So if you have obesity, losing weight can actually improve reflux symptoms. It may not get rid of it completely because there may be other mechanisms contributing to the reflux, but it has been shown to significantly improve symptoms. Smoking cessation also seems to be a good modifiable risk factor. Patients who smoke who then cut out the tobacco use actually can have an improvement in their symptoms. It's also important to tell patients not to eat so late before they lie down, or not to take a nap right after they've had their lunch, for instance, because you lose the effect of gravity to help the food push more towards the antrum and then out through the pylorus. And if you're lying down, you lose that effect. You're more prone to reflux. And if they do have dietary triggers, you may want to focus on either cutting down or cutting out that food, but not doing this blanket cutting out of all types of foods that are known to be potential triggers. So if the patient drinks coffee and they don't feel worse, they don't have to cut it out. Let's talk about some coexisting disorders. Well, if a patient has a large hiatal hernia, which you see right here in a retroflex view on endoscopy, that can lead to still reflux of stomach contents that, despite cutting down on the acid production, it's not going to make much of a difference. Eosinophilic esophagitis, which Dr. Ovsiewicz talked about in good detail, is another coexisting disorder. In fact, we can have patients who have concomitant EOE and reflux. Gastroparesis, again, one of the mechanisms that I mentioned was you can have delayed gastric emptying, and even if you block the acid production, you're still going to have reflux of contents because you're not emptying very well. And then any kind of dysmotility, I highlight scleroderma or systemic sclerosis, but any kind of motility problem can lead to reflux because you're not clearing contents out of the esophagus. Now let's shift over to the non-responders. These are the patients who, even if you put them on a twice-a-day PPI, they really don't notice any difference in their symptoms. And the data in the medical literature really supports the notion that switching to another proton pump inhibitor is really not going to provide any additional benefit. We see it once in a while, but it's so rare that that shouldn't be the first thing tried. So if you have someone like this, you might want to consider that maybe there's something else going on. Maybe they're having regurgitation. Well, regurgitation is a symptom of reflux, but regurgitation can be acidic, it can be non-acidic. There's also non-acidic reflux, meaning just the fluid has now been acid depleted, and that's still refluxing up. Eosinophilic esophagitis I'll just touch upon because that's been described in more detail, as well as achalasia, and then I'll bring up the concept of functional heartburn. And then if you have a patient who does not have the typical symptoms of reflux and does not get better with a proton pump inhibitor, you really have to think of something else, especially outside of the GI tract. So regurgitation, this is not my kid, but if I saw that, I'd be freaked out. So as I mentioned, regurgitation is a typical reflux symptom, and usually patients who have regurgitation but are taking a PPI, instead of having a sour or burning type of regurgitant, it'll be very bland tasting. The only way that you're going to help take care of these patients is to perform an anti-reflux surgery. I'll talk about that towards the end of the talk. All right, non-acid reflux. As I mentioned, you can take the acid out of the reflux, but you can't take the reflux away completely. So non-acid reflux implies that it's just acid-depleted fluid. And patients with non-acid reflux are more likely to have the extraesophageal manifestations, such as throat clearing or a frequent cough. If you have a patient who has been confirmed by objective testing to have reflux, and you then test them while on a proton pump inhibitor with a study called an impedance pH test, this actually measures fluid content, and we combine it with the pH test at the same time to determine whether the fluid is acidic or non-acidic. This can help to document that non-acid reflux is occurring. Treatments include anti-reflux surgery and a medication called baclofen, which helps to reduce the frequency of transient relaxations of the lower esophageal sphincter. Big downside to this medication is that it causes pretty profound somnolence in about half of patients, so to the point where they can't take the medication because they can't function. So it's something to try, and if it helps, it maybe is a better predictor that these patients will respond to an anti-reflux surgery. One slide on EOE. Although the most common symptom in EOE is dysphagia to solid foods, heartburn is number 2 symptom. These patients will require an endoscopy to look for EOE and take biopsies to confirm the number of eosinophils, as Dr. Osiewicz had mentioned. Treatment. Well, proton pump inhibitors for some of these patients actually can help, but you have to consider other treatments such as topical swallowed steroids and specific food elimination. Achalasia is defined as a failure of the lower esophageal sphincter to relax, and you will also have a lack of peristalsis. This is the quite classic appearance on barium esophagram, where you have a very tapered distal esophagus to what's described as a bird's beak right here, and then you have the dilated esophagus. These patients may have the perception of heartburn, but they're not actually having reflux. So what's happening is the food and the fluid is just sitting in the esophagus, and just the local digestive enzymes are actually leading to fermentation, which then leads to a burning perception. And in fact, this is actually protective against reflux because the sphincter doesn't open. Functional heartburn. So this is basically where the patient has heartburn, but they don't respond to proton pump inhibitor. You look at them by endoscopy, everything looks normal. You test them by pH testing off of PPI, there's no reflux. And you do a esophageal manometry, and everything is normal. So essentially all there is the symptom. So the thought here is that the patients have some kind of hypersensitive response with regard to the interaction between the esophagus and the nerves that innervate it. And so this leads to a perception of symptoms. There are various modalities, which a later speaker will talk about treatment of functional gastrointestinal disorders. I will leave that to Dr. Connolly, who will be doing that. Getting close to the end, but just to kind of summarize the workup, if you have a patient, or if we see a patient who comes in on a twice-a-day PPI, not feeling any better, what we do is we say, look, we got to confirm the diagnosis or rule it out. We take them off of the PPI for 7 days, and then we do some type of pH testing, whether it's a wireless pH test or a catheter-based pH test. And looking down the left-hand side, if it's normal, you've ruled out GERD, or at least you can say that it's extremely unlikely. So if they have the typical symptoms of reflux, you want to consider things like functional heartburn or not even non-cardiac chest pain if their main symptom is pain. If they have the extraesophageal symptoms, as I mentioned before, look elsewhere. Or have another doctor look elsewhere. Now, if they do have acid exposure, well, then they have reflux. So you want to make sure that they're taking the medication the right way, they're adhering to the lifestyle changes that they haven't been adhering to beforehand. And if they still don't respond, then we have them do this impedance pH test on PPI to see if there is a presence of persistent non-acid reflux. If they do have persistent acid, though, it sounds like, look, you're just not going to get any more effect from the PPI. You may need to consider this patient for anti-reflux surgery. If they have just non-acid reflux, then you might think that they're just a little bit more hypersensitive just to the fluid bathing the esophagus, and there are a variety of treatments, which I won't get into, that can be used in that regard. And if there's no association between reflux and their symptoms, then you want to consider that they probably have just another disorder as well as reflux. So I'll finish up talking about anti-reflux surgery. This is actually a good option for long-term reflux control, especially if you have a young patient who responds to PPIs. They're probably going to respond very well to surgery, and it's a very good likelihood that they won't require ongoing use of medications. It's been shown to be as effective, and in some studies more effective, than medical management for GERD. And these patients, if you're going to consider them for surgery, they need to undergo a preoperative evaluation. So what is that evaluation? First of all, you want to rule out any other diagnoses that would make surgery contraindicated. And in particular, this is eosinophilic esophagitis, achalasia, and other significant motility disorders such as scleroderma. The pre-op evaluation includes an upper endoscopy, doing some type of reflux testing off of proton pump inhibitors to confirm the diagnosis of reflux. And so here you have a picture of a normal esophageal manometry, nice and colorful. And then this is what the wireless pH probe looks like we place during an endoscopy. And it sends the information to a recorder that you wear on your belt or around your neck for a couple of days. And with this combination of testing, if they're adequate candidates from a medical standpoint, they can undergo the surgery. So what are the surgical options? The two most common ones are the fundoplication. You see a picture of that to the right. And then I'll talk about a sphincter augmentation device in just a moment. So there are three fundoplication types. There's the Nissen, or full 360-degree wrap of the fundus around the esophagus, a toupet, which is a posterior 270-degree wrap, and then the door, which is an anterior 180-degree wrap. Now, looking at the literature, it's actually quite varied in terms of what's the best thing to do for the patient, or in terms of which type of fundoplication. And the Nissen, it makes the most sense that it would probably have the most effect, but if patients have some degree of hypomotility that doesn't necessarily clear-cut fit into scleroderma, for instance, they can still get the fundoplication, but the full wrap may actually lead to postoperative dysphagia. And so there were studies that said that between the Nissen and the toupet, there were actually pretty good outcomes, but they didn't really determine what the preoperative motility pattern was like. Then there was a comparison with the door and these other two fundoplications, and they found that in patients who had motility problems, this was just as effective but led to less postoperative dysphagia. So probably the best option is to have your surgeon, who has the most expertise with this, discuss with the patients what would be the best type of fundoplication after having undergone the preoperative evaluation. Now, I talked about it being, the fundoplication being a really good option for people who respond to PPIs. How about for the people who have the extraesophageal or less typical symptoms? Well, this was a study done now 3 years ago, and they looked at patients who had undergone fundoplication, but they looked at their preoperative evaluation to determine what were the biggest predictors for success. And as you can see, the best candidates are those who have also, in addition to their extraesophageal symptoms, typical symptoms such as heartburn, and a significant amount of acid exposure in the esophagus. This is actually more than double the upper limit of normal. That's close to like 90%. About 50% of people who have evidence of reflux but don't have the heartburn will be responsive to the fundoplication little bit less so if you have the heartburn but no evidence of reflux. And then people who really don't have either heartburn or pathologic reflux on pH testing, these are the people you don't want to be doing the fundoplication on if they just have the extra esophageal symptoms. Now, no surgery is going to be good as new. Fundoplication does have a lot of potential for complications. The most common is what's called gas bloat syndrome. So you've prevented reflux, but you might also prevent being able to vent, and so that will lead to bloating. People may actually end up getting diarrhea or excess flatus because of that. Dysphagia is fairly common, especially in the early postoperative period, but usually by 12 weeks the dysphagia should resolve. However, in up to 25% of patients, there is persistent dysphagia, which may require either dilation of the GE junction because it was too tight of a wrap, and in some cases, the fundoplication needed to be revised. And even though the goal is to prevent the reflux, up to 60% of patients can have recurrent heartburn requiring concomitant use of PPIs. So for some patients, this magnetic bracelet called the LINX, which is a sphincter augmentation device, has been developed. It's been around for about 6 years. And what it is a string of magnetic beads that's wrapped in a titanium case. And each bead is connected to the adjacent tube, but it's not one consistent string around. So each one can separate from the other, even if the other ones stay closed. Now, the goal behind this is to provide more strength to the GE junction. And so when you swallow, the propulsive force of the food bolus will actually overcome the magnetic force. Food goes down. However, the force for reflux is much lower than that for the food bolus, and so this prevents the reflux. However, belching and even the ability to vomit are still maintained in these patients because those forces can still overcome the magnetic force, and so this has been a big advantage for patients compared to the fundoplication. However, it's not for everyone. First of all, you can't have an MRI if you have this in. If you have a hiatal hernia that's 3 centimeters or greater concomitantly, you cannot get this done, at least at this point in time. The company actually says that that's a contraindication. And it's not been studied in people who have severe reflux esophagitis, only the milder type. So we'll see how it goes in the long term. We have 6-year data that says that for the very limited scope of its use, it seems to be quite effective and well tolerated. So to summarize, although proton pump inhibitors are the mainstay for reflux, and there is little difference among the PPIs, not all patients are going to respond, and so you have to look to see, are they responding to some degree, in which case you may have to change the dose or the timing of the dose. You want to make sure that the patients are adhering to the good lifestyle practices. If they're not responding at all to the PPIs, then you really want to look into this more investigated to rule out reflux or look for a concomitant or other diagnosis that would explain the symptoms. And there is a role for anti-reflux surgery for both typical and atypical symptoms, but it does require a preoperative evaluation to make sure that they're going to have the most likelihood of response. Thank you very much.